starting with the first free paper. This is of Dr. Shruti Kirti Parida. I think you can start with your presentation. And just stick to the guideline, the time frame and everything.
A very good afternoon to one and all. My study is titled Etiology, Management and Visual Prognosis in Patients with Orbital Apex Syndrome. I have no financial interest to disclose. As we all know, orbital apex syndrome is characterized by vision loss, ophthalmoplegia, periorbital pain, ptosis, proptosis, with or without diplopia. Also, the patient can have a diminished corneal sensation with or without hyperesthesia of the forehead and the face. The etiologies are varied, and it occurs due to the involvement of the anatomical structures at the apex of the orbit because of compression, vasculitis, or direct invasion. High-resolution contrast-enhanced MRI brain and orbit, mainly the fat-sat scans, help in the most accurate characterization of the pathological processes involving the orbital apex. The aim of the study was to determine the etiology, management, and visual prognosis in patients with orbital apex syndrome and to find out the predictors of final visual outcomes. This was basically a prospective interventional study. 15 patients who were diagnosed with orbital apex syndrome were included, and the study period was from January to June 2024. A detailed ocular and systemic evaluation was done, and patients were managed as per the underlying etiology. A minimum of 3 months of follow-up was done. A detailed statistical analysis was done, and a p-value less than 0.05 was considered significant. Now coming to the results. The mean age of the study participants was 34.67 plus minus 0.38 years, and there was a male preponderance with a male-female ratio of 1.5:1. In the etiology, most commonly there was infective etiology accounting for around 53 to 54%, followed by neoplastic, which was seen in 27%, and then traumatic in 20%. In the neoplastic, nasopharyngeal carcinoma was found in 2%. No organisms were isolated in 7 patients, whereas among the organisms isolated, staph species were most common. In the ocular symptoms, diminution of vision followed by drooping of the eyelid was most common, whereas headache followed by fever were the most common systemic symptoms. This was the data of the treatment given as per the etiology. Now comparing the best corrected visual acuity of the affected eye, there was a significant improvement from presentation to a final follow-up from 2.06 logMAR units to 1.05 logMAR units. There was also a significant improvement of the pupillary status from a grade 2 RAPD, which was more common at presentation, to a sluggish pupillary reaction at final follow-up. We did the univariate and multivariate linear regression analysis, and these are the factors which affected the final visual outcomes, including the best corrected visual acuity at presentation, systemic comorbidities, fever at presentation, neoplastic etiology, pupillary abnormalities of higher grade like grade 2, 3, 4, and anisocoria, and advanced field loss at presentation. Now coming to the discussion. In a study by Lee et al. On 20 cases, there was a male preponderance with unilateral presentation, and neoplasm was the most common cause, followed by inflammation and infections. But there was no significant differences in the initial and post-treatment final best corrected visual acuity. Neoplastic causes had a poor visual prognosis. In a study by Talwar et al. On 117 cases, 51.7% experienced improvement in vision and 85% in ophthalmoplegia at 6 months. In a study by Ribeiro et al., similarly, the delayed diagnosis led to fatal outcomes. In a study by Schindler et al. In 4 cases of nasopharyngeal rhabdomyosarcoma causing orbital apex, the average age at presentation was 4 plus minus 1.4 years, and the ocular motility recovered in almost all patients, whereas there was little or no recovery of visual acuity at final follow-up. But in our present study, there was a male preponderance. The mean age was 34.67 plus minus 0.38 years. Most common etiology was infective, followed by neoplastic, and the most common agent isolated was staph aureus. The most common ocular symptoms were diminished vision with drooping of the eyelid, and headache and fever were the most common systemic symptoms. As there was the infective etiology followed by traumatic, most commonly seen in our study, there was a significant improvement in the final follow-up with a p-value of VCBA of 0.0001. Orbital apex syndrome has a paucity of literature. Mostly there are small-scale studies because of the rarity of this disease and heterogeneity of the underlying etiologies. Most patients experience poor visual prognosis despite aggressive multidisciplinary management. And the patients with neoplastic etiologies have a unfavorable outcome as compared to those with a non-neoplastic etiology. because mostly they are diagnosed at a later stage. So to conclude, a careful clinical workup, relevant laboratory investigation, spatial diagnostic modalities, along with the neuroimaging are the crux to establish the correct diagnosis and start adequate treatment. Delayed diagnosis and treatment, presence of neoplastic etiology, presence of systemic comorbidities, and severe visual impairment at presentation are the predictors of poor visual prognosis. There is a need for large-scale studies with more sample size to widen the knowledge about this entity. Thank you.
You have mentioned about the isolates of that organisms. How you got the sample?
So we got the samples like the patients in the infective patients who are having the infective patients like in sinusitis or we did like it was a multi-speciality hospital. So we sent the patient to ENT department and then they did the endoscopy and they got the samples.
So in every case they did the endoscopy?
In possible cases we did the endoscopy.
So you said your type of study is prospective interventional. What intervention did you do?
Like in the infective etiology, we started them on intravenous followed by the oral antibiotics. And in cases with traumatic, we then started the patients on intravenous methylprednisolone. And in neoplastic etiology, the patients were sent to the concerned like ENT surgeon or the neurosurgeon for the management like radiotherapy or the surgical debulking was done.
But according to your conclusion, the study seems to be more of a observation, like you're observing which one is having a risk factor of developing this kind of vision at the end, no? So it's not like you're comparing in antibiotics versus surgery. So you can change the type of study from prospective interventional because you're not studying the intervention, you're studying the risk factors.
Yeah, but actually, except the neoplastic etiology, the patients who were having infective etiology and traumatic, we got them admitted in our ophthalmology ward and we gave them intravenous antibiotics and intravenous methylprednisolone. So in a way that is interventional. Otherwise, that neoplastic patients, they were followed up in other departments and then they came for follow-up to us.
But a significant number was of trauma.
So
A significant number of your etiology?
no, 8 patients had infective, then 4 had neoplastic, 3 had trauma out of the 15 patients.
Out of the 15 patients?
Yeah.
So there was no need to have any intervention in trauma patient? What was done in trauma patient?
In the trauma patients, like they had who were
And
having.
how you have that shown that this is because of trauma, the orbital apex syndrome? It was some CT was done?
Yeah, NCCT, CT orbit, and MRI was done in those patients. We did all the neuroimaging in the patients. Along with the neurosurgery department, because it was a multi-speciality hospital, so along with them, combinedly, we did all these new investigations, and then the patients who were needing that maxillofacial surgery, they underwent maxillofacial surgery, and who were having like traumatic brain injury, they were managed as per the case. And then we started, after taking the neurosurgeon opinion, then we started them on intravenous methylprednisolone for the trauma cases, followed by tapering oral doses.
When you negate everything, then you start IV methylprednisolone.
Yeah. After ruling out all the etiologies, then we started on IVMP.
Okay, thank you. Next one is
Dr. Priyadarshini PV. Okay. Go ahead.
Yes, sir. Now I will be discussing about diagnostic insights into abducens nerve palsy at a tertiary eye care facility in South India. While learning about abducens nerve palsy and its etiological aspect is important because it has a very long intracranial course and hence it is more prone for injury at multiple sites. The incidence is around 11.3 in 1 lakh population and it can be unilateral or bilateral, congenital or acquired, and complete or partial. The pathogenesis involves lesion anywhere along its course from pons to the lateral rectus, which results in impact abduction and incontinent esotropia. Immediate evaluation is important since timely diagnosis and management aids in better prognosis. The investigations include random blood sugar, glycosylated hemoglobin, blood pressure, lipid profile, erythrocyte sedimentation rate to rule out inflammatory causes, and MRI brain to rule out space-occupying lesion, and MR angiography to rule out vascular lesions such as aneurysm or thrombosis. The management involves treating the underlying causes such as diabetes mellitus, hypertension, raised intracranial pressure, or infection. The supportive care therapy involves eye patch or prism glasses to alleviate the symptoms of diplopia, and medical therapy involves steroids in case of inflammation and botulinum toxin in case of contracture of its ipsilateral antagonist muscle. The surgical correction is usually indicated when there is persistent diplopia or restriction of extraocular muscle movements for more than 6 months. The rehabilitation therapy involves eye exercises. The purpose of my study was to elucidate the clinical characteristics and etiological diversity of abducens nerve palsy at a tertiary eye care facility in South India. And it was a retrospective study done in Department of Neuro Ophthalmology, and it was done for a period of 1 year. A total of 601 patients were included in the study, and all patients presenting with sixth nerve palsy were included in the study, and patients with infantile esotropia, spasm of medial rectus, and Duven's retraction syndrome were excluded from the study. Considering the gender distribution in patients with sixth nerve palsy, it has been found that majority were males compared to females, with an incidence of about 62% in males and 38% in females. Epidemiological analysis showed that sixth nerve showed an age-specific stratification, with more than 80% of the population presenting more than 40 years of age. The subgroup analysis showed that 50 to 60 year subgroup and 60 to 70 year subgroup contributed to nearly 60% of the total cases, that is nearly 2/3 of the total cases. Since sixth nerve, it has a very varied and wide diverse etiological spectrum, it has been found that ischemic cause is more prevalent compared to all other causes, with an incidence of around 72% in ischemic causes, followed by inflammatory, space-occupying lesion, trauma, false localizing sign secondary to idiopathic intracranial hypertension, infective, vascular, and demyelinating lesions. It has been found that 94% of the cases were unilateral compared to bilateral, which has a proportion of about 6%. Among the unilateral cases, again, ischemic cause is more prevalent than all other causes, with a proportion of about 74%. And among the bilateral causes, again, ischemic cause, it predominates over all other causes, with a proportion of about 33%. Metabolic comorbidities were found in significant proportions in patients with sixth nerve palsy, with 21% in diabetes mellitus and 12% in systemic hypertension. I would like to summarize by telling that a total of 601 patients were included in the study, with an age group of 51 plus or minus 14 years, and majority were males and unilateral. The most common etiology identified was ischemic cause, and among them 74% were unilateral and 33% were bilateral. 7 cases of demyelinating lesions were found, which were due to multiple sclerosis causing a partial sixth nerve palsy. And the first picture shows a right nasopharyngeal carcinoma invading the right clivus, causing isolated sixth nerve palsy. And the second picture shows a nodular enhancing lesion in the left sixth nerve secondary to schwannoma. I would like to conclude by telling that the prognosis and the natural course varied depending on the etiology. Patients with sixth nerve palsy have causes other than idiopathic or microvascular etiology than expected rates. We must also bear in mind that patients under the age of 50 years with sixth nerve palsy and in the absence of microvascular risk factors, neuroimaging, especially MRI with MR angiography of the brain, should be considered. Considering the incidence of space-occupying lesion in the sixth nerve palsy, and since sixth nerve is also known as the tumor nerve, it is better to do neuroimaging in all patients with sixth nerve palsy. Thank you.
Which aneurysm do you consider important for your sixth nerve palsy?
Sir?
Which aneurysm do you consider is important? Because you have done MRA, because
Yes,
it was
sir.
a retrospective study of 601 patients. That means each and every patient has undergone MRI with MRA.
Yes, sir.
But you have not written about the contrast, because you have shown nasopharyngeal carcinoma,
Yes, sir.
and other one is your
Schwannoma, sir.
schwannoma.
Yes, sir.
So, but you have not ordered MRI with contrast, but you ordered MRI with MRA. So all the 601 patients have undergone MRI with MRA. So I don't think a MRA is needed in sixth nerve, even if the microvascular complication
Yes,
is
sir.
there, ischemic is there.
So considering the
which aneurysm do you consider would be causing sixth nerve paralysis? Or
either
palsy?
posterior cerebellar artery aneurysm or anterior inferior cerebellar artery aneurysm can cause
Posterior
sixth.
cerebellar artery aneurysm.
Yes, sir.
Okay. What about your ICA aneurysm? I can think of ICA aneurysm in the cavernous sinus that would be causing your third nerve
Intrapetrosal
and then
segment
your
of
other
internal
nerve,
carotid
but
artery, sir.
not isolated sixth nerve palsy with any aneurysm.
Intrapetrosal
Reason for
segment.
asking this question is why they have unnecessarily been subjected to MRA. If you have ordered MRI with MR or with contrast, then it would have been okay. And
Sir,
601 patient MRA, because it takes another 15 to 20 minutes to do the MRA.
Sir, we didn't do neuroimaging in all patients with sixth nerve palsy, sir. Considering the patient is more than 50
Because
years.
you have not written about that, ki the all patient have not undergone MRI with MRA. You have not written. That is the reason I'm asking. Because it's a huge number, na, 601.
Yes, sir.
So, you said in the conclusion, prognosis depends on the etiology.
Yes, ma'am.
So, what did you do in the study that made you say this? What was the prognosis that you checked?
Considering the patient age group, ma'am, when the patient is more than 50 years and when there is any metabolic comorbidities which has been associated, we initially observe the patient and we used to call the patient after 1 month, ma'am. When the symptoms are improving, then we will follow up the patient for another 3 months, ma'am. And if there is no improvement of the symptom which is noted at that time, then we will indicate neuroimaging in such patients, ma'am.
No, because in your conclusion you said outcome.
Yes, ma'am.
So you have to have some outcome. No, you must have checked something.
Yes, ma'am.
Did you check the vision?
Mostly
Did you check the
patients-
deviation?
Yes,
What
ma'am.
did you check?
Mostly patients with microischemic causes, they improved, ma'am. But patients who were presenting with traumatic sixth nerve palsy, they didn't show significant improvement, and there is persistence of diplopia, and also there is restriction of extraocular movements beyond
So
6 months,
that
ma'am.
you have to add. How much did the deviation improve? What was the improvement? That has to be added to come to that conclusion.
Yes, ma'am.
Thank you. Dr. Vidya Dharini.
Good afternoon. I'll be talking about IIH in children. Pediatric IIH is uncommon. In children, the CSF opening pressure has to be more than 28 centimeters of water or more than 25 if the child is not obese and not sedated. The aim of this study was to understand the clinical profile and treatment outcome of IIH in children. A retrospective study where the electronic medical record of 7 children were analyzed. The inclusion criteria was children less than 18 years of age with a minimum follow-up 6 months. Any intracranial pathology and those children with renal failure were excluded. The age ranged from 1 to 17 years, with the youngest child being 1 year of age. The male-female ratio was 4:3. 4 children in this study were obese and 3 had a normal BMI. 5 children came to us within 1 to 2 weeks of onset of symptoms, while 2 children came a month later. The most common presenting symptoms were headache and double vision. 5 children had best-corrected visual acuity and color vision being normal, while it was defective in 1 child who had fulminant IIH. The 1-year-old child was able to follow and fix light. The common signs what we came across was abduction limitation in 6 patients, bilateral disc edema was present in 6 patients, and was normal in 1 child. The disc was normal in 1 child, indicating IIH without papillary edema. The visual field defect most commonly we came across was enlarged blind spot. The child with fulminant IIH had constricted visual fields. Even though there is no normative data for OCT in children less than 18 years, it is still done as it helps in monitoring response to treatment. Neuroimaging showed widened perioptic CSF space in 6 patients. Surprisingly, no features of raised ICP were seen in that child with normal optic disc. Management, lumbar puncture was done all to record the CSF opening pressure, which ranged between 25 to 40 centimeters of water. All children received tablet acetazolamide. The older children were also given a trial of furosemide, oral glycerol, and injection mannitol. These medications were gradually tapered based on resolution of symptoms and disc edema. Bilateral optic nerve sheath fenestration was done in the child with fulminant IIH. The treatment duration varied between 3 to 9 months. Healthy lifestyle, weight loss was encouraged in each visit. All had good recovery except the patient with fulminant IIH. 1 child had recurrence of the disease 2 years later following excessive weight gain. So the table synopsis. Moving on to discussion, IIH as an adult is always a diagnosis of exclusion. Its pathophysiology is unclear. The theories surrounding CSF dynamics either include decreased CSF drainage or excessive CSF production. So is the pathophysiology in children different? Well, Margaret et al., they demonstrated lower levels of CSF protein in prepubertal children, reflecting overproduction of CSF rather than a reduced drainage. What about the gender predilection? Various studies by Genzi et al. And Balser, they said that in the prepubertal group, there was no significant difference. That means there was an equal incidence between male and female, but as age advanced, the incidence was more among females, especially in obese postpubertal females. In our study, 4 children who were less than 12 years and prepubertal were all males, and all the postpubertal patients were females. There is an association between pediatric IIH and prevalence of obesity with increasing age. This thing was supported by Sheldon et al. He said that the younger the patients, the BMI Z values were normal, but in early adolescent and late adolescent, they were hovering around the overweight and obese reference levels. In our patient, 2 children who were less than 12 years and 1 patient in the post-pubertal group had normal BMI, rest were obese. The most common symptoms children can present with are headache, tinnitus, and diplopia. 50% of children are symptomatic when compared to 20% of adults. Optic nerve edema is the most common sign. Rarely, children can present with symptoms of raised ICP without papilledema. Management is multidisciplinary and must include a nutritionist. Mitigation of symptoms, preventing permanent vision loss is the goal. No RCT studies in children are available till date. Recurrence can occur, especially in those children who lose weight initially and regain it. To conclude, pediatric IIH is uncommon and less frequently reported. There are multiple diagnostic snags which we come across, especially those diagnostic investigations such as LP and for MRI which can need general anesthesia or sedation. Despite these hurdles, accurate diagnosis is mandatory to prevent permanent vision loss and poor quality of life. With obesity emerging as a major risk factor, adverse effects of obesity must be there in primary caregivers, and a healthy lifestyle must be emphasized. Thank you.
Definitely a difficult study because pediatric IIH, very difficult to measure the CSF. How the CSF was measured? It was by the pediatric neurologist?
Yes, sir. Pediatric neurology. All children were referred to pediatric neurology.
All were done under sedation?
No, only those 5 years, 1-year-old child and 1 12-year-old child needed sedation. Others cooperated.
Because you have written headache and diplopia was the main symptom.
Yes, sir.
How that 1-year-old child came to your department?
The presenting symptom was, it was referred to us by the pediatric neurology department, pediatric ophthalmology department. The sudden onset of face turn, that's what the parents noted. The child had an AHP for which they were brought to the eye institute.
And MRV with contrast was done in every patient?
No, sir. A plain MRV was done. If there was any suspicion of it, then a contrast was administered. So all these patients on a basic run through the MRV was normal.
So that means all the MRVs were normal?
Yes, sir.
No sinus involvement?
Not at all. Not in one child.
Involvement was not there?
No.
Any hypoplasia of transverse sinus? Any stenosis?
Not at all. No.
No. Quite strange.
So how did you check the vision?
The senile starting, basic senile starting was done. That was used to check the visual acuity. Humphrey's perimetry for visual field assessment, and Ishihara's chart for color vision.
So like you wrote BCVA is normal, no? So usually in studies you have to mention what is the BCVA which was noted, either a range.
Okay.
You have to write that, which method was used. Whenever you're conducting a study, like you can't write it's just normal or defective like that. It has to be written a proper
More
method.
elaborate.
Yeah. So one child you said had normal optic disc
Yes.
and normal MRI also.
Yes.
So how did you suspect IIH in that child
The
then?
symptoms were of raised ICP, headache, diplopia, nausea. The child also had tinnitus too. With this, we neuroimaged. Neuroimaging was normal. So when we did go ahead with the lumbar puncture, there the CSF opening pressure was 34 centimeters or what. Thank you.
Is the next one? Dr. Priya Suman is there? No. Dr. Gagandeep Kaur? Dr. Maheshwaran K?
I am going to present a rare case of abducens nerve palsy due to fungal sinusitis with the cavernous sinus involvement. 39-year-old male present with complaints of binocular double vision for 1 day with horizontal separation of images, more on left lateral gaze. There was no history of trauma, defective vision, nausea, vomiting, and no history of previous surgeries. There was no relevant past history. He's a known diabetic for 2 years and is a known alcoholic for 6 years. In general examination, he was conscious oriented, moderately built and well nourished, and systemic examinations were normal. His vitals were stable, and the random blood sugar was 227 mg per deciliter, HbA1c 10.4%. On ocular examination, his right eye best corrected visual acuity was 6.9, and in investigation, intraocular pressure by non-contact tonometry 70 mm mercury, and his color vision was normal. In left eye best corrected visual acuity 612 partial, intraocular pressure by non-contact tonometry 40 mm mercury, color vision was normal. In anterior examination, he had both a posterior polar cataract. And on paratic squint evaluation, he had a small angle esotropia in left eye. In cover test, he had alternate esotropia with the right eye dominance. In extraocular examination, he had a left eye obstruction restriction present. Able to appreciate the left eye obstruction restriction, left eye levo elevation restriction, levo depression restriction. In posterior segment examination, everything was within normal limit. So ordered a MRI with MRI brain. In T1 weighted post contrast, in axial view, we can able to appreciate the ethmoidal sinusitis. In coronal view, we can appreciate the macular sinusitis. In sagittal view, we can able to note the sphenoidal sinusitis. In coronal view, there was a cavernous sinus involvement noted. So based on the MRI with MRI, there was a semi-invasive fungal sinusitis with involvement of right macular artery, both ethmoidal and sphenoid sinus, and minimal left cavernous sinus extension. So the diagnosis was sixth cranial nerve palsy due to invasive fungal sinusitis with the cavernous sinus extension with both a posterior polar cataract. Patient was referred to ENT surgeon. Then he underwent functional endoscopic sinus surgery. There was a complete resolution after within 1 week of surgery and discussion. Abduction nerve palsy is the most common cranial nerve palsy. Due to its long intracranial course and its dual attachment to the skull base, it is more vulnerable to variable inserts. Etiologies are hypertension, diabetes, trauma, multiple sclerosis, neoplasm, cerebrovascular accident, post-neurosurgery. In my case, diabetes is a known case of diabetes, most probably due to the immunocompromised state. Clinical features are symptoms are binocular diplopia with horizontal separation of images, more on lateral gaze. Signs are abduction restriction, uncrossed diplopia, first face turned towards the side of diplopia. Treatment like in antifungal medications, broad spectrum antibiotic medication, surgical intervention to decompress any space occupying debris and purulence. In prognosis, for lesions like benign and non-invasive lesions, it leads to a complete resolution. In case of lesions which invading the nerve and its blood supply, it leads to partial or no resolutions only. A similar case reported by W.S. Leong, 6-nerve cranial palsy, secondary spinal sinusitis, treated with endoscopic transnasal splenectomy. Patient was recovered completely after 3 months. There is another case reported by L. Theoris et al. Reported a case of 6-nerve palsy due to spinal sinusitis. In patient was treated with endoscopic transnasal splenectomy. Intraoperatively, they visualized larger fungal ball in the spinal sinus. Patient was completely recovered 4 days after surgery. These are my references. So, it is a rare case but treatable. Early treatment with appropriate medical management, surgical decompression, it lead to excellent prognosis. Patients with history of diabetes with comes with a sudden onset of diplopia, we should rule out infections like sinusitis also.
Was the patient on insulin?
No sir, on oral OHA only.
Only OHA. And what about that your cavernous sinus? What happened to that lesion, because it was the extension into the cavernous sinus also?
Yes sir.
Because you mentioned that 1 week after the surgery, I think endoscopic sphenoid clearance was done.
Yeah, they did functional endoscopic sinus surgery, sir. Followed that they amputated CMB and taxim also given.
So how did you rule out all the other cranial nerves, because so close to cavernous sinus, no?
So the anterior part of the cavernous sinus was involved, no? It was anterior or whole of the cavernous sinus? The mid and the posterior? Because you have shown only one coronal section.
Yes sir. Based on the contrast.
No, which part of the cavernous sinus? It was only anterior part, because the madam has asked regarding the other cranial nerve, because it is cavernous sinus.
Yes.
Definitely the other cranial nerves.
So 6 nerve in the medial wall, so most proximal to the paranasal sinus. There is a minimal invasion, so probability to the medial walls.
So
There is
what
no definition of minimal invasion, no?
What examinations did you do to rule out the other cranial nerves?
I checked for the taste sensation, ma'am.
Which sensation?
I checked taste sensation.
No, the ones which are near cavernous sinus, no? How did you check that?
What about the V1 and V2?
I check for ocular sensation also.
Corneal sensation.
Corneal,
also.
corneal sensation.
Only corneal sensations. The V2 area was not checked.
Um,
Everything was okay till the cavernous sinus is involved. Na? That is the reason we are asking. Okay, thank you. Dr. Karthik.
Good afternoon, everyone. My presentation will be on advancing diagnostics in IIH, a trimodal investigation of optic nerve sheath measurements. Idiopathic intracranial hypertension is characterized by increased intracranial pressure without an apparent cause, often leading to symptoms like severe headache and vision problems, primarily affecting women of childbearing age who are overweight, and it is diagnosed by modified Dandy criteria with the symptoms of a headache, nausea, vomiting, transient obscuration of vision with papilledema, and neuroimaging showing no apparent cause, and no localizing sign except for lateral rectus palsy, and elevated CSF pressure more than or equal to 23 centimeters of water with normal CSF composition. So it is primarily a diagnosis of exclusion. So classically MRI with MRV are used for diagnosis and follow-up of IIH patients. Findings such as empty cella, optic nerve tortuosity with distension of optic nerve sheath, posterior globe flattening, venous sinus stenosis are found to be helpful in diagnosing the condition. In lumbar puncture, opening pressure of 25 centimeter or more with the normal CSF composition confirms the diagnosis of IIH. The optic nerve is enveloped by meninges that extend from the brain, creating a subarachnoid space filled with cerebrospinal fluid. In IIH, increased intracranial pressure expands this space, increasing optic nerve sheath diameter. Hence, optic nerve sheath diameter is a valuable and non-invasive marker for detecting elevated ICP in idiopathic intracranial hypertension. So we aimed to do this study with the primary objective to correlate optic nerve sheath diameter measured by orbital ultrasound with that measured by MRI, and with the secondary objectives to assess the relationship between CSF opening pressure and optic nerve sheath diameter by MRI and ultrasound, and to evaluate the utility of ultrasound as a monitoring tool. So we did this prospective observational study over 2 years period from September 2020 to September 2022 with 50 patients presenting with papilledema to Neuro Ophthalmology department. Patients over 18 years of age who satisfied modified anti-diagnostic criteria for IIH were included in the study. History of optic neuropathy, intracranial masses in neuroimaging, and lack of consent were all excluded. Sorry. This flow chart summarizes the investigation process, starting with patient consent and clinical evaluation, followed by eligibility assessment, followed by imaging with ultrasound and MRI, and CSF pressure measurement by lumbar puncture, and ongoing follow-up with ultrasound. In ultrasound B scan, optic nerve sheath diameter was measured at 30-degree lateral gaze during the axial scan, 3 mm behind the globe. Increased ICP is theorized to significantly reduce the sheath width when the nerve is stretched. Here I am presenting a case of 35-year-old female who presented with severe headache, nausea and blurred vision. Her fundus showed grade 4 papilledema in both eyes. MRI was done and she underwent imaging and CSF pressure measurement. And her MRI showed partial empty cella with optic nerve sheath diameter of 7 mm in right eye and 6.9 mm in left eye, and it was measured 3 mm behind the globe. And before lumbar puncture, ultrasound was done. In in ultrasound B scan, the optic nerve sheath diameter was 7.1 mm in right eye and 6.9 mm in the left eye. Ultrasound optic nerve sheath measurement was measured separately and it was comparable to MRI. It was performed by separate professionals who were blinded for the outcomes. Post-lumbar puncture showed reduction in optic nerve sheath diameter. We repeated similar study in all 50 patients And we found most participants are aged 18 to 35 years with clear female predominance of 90%. And there was a strong positive correlation observed between CSF opening pressure and closing pressure, showing intracranial tension significantly reduced after lumbar puncture. And this scatter plot shows a significant positive correlation between the optic nerve sheath diameter and cerebrospinal fluid opening pressure, emphasizing the relationship between intracranial pressure and optic nerve sheath diameter. And the optic nerve sheath measurements through ultrasound B scan, the average was 6.8 millimeter plus or minus 0.5 millimeter, and by MRI it was 6.6 millimeter plus or minus 0.6 millimeter, which exhibited a strong positive correlation with Pearson coefficient of 0.84. And also the trend analysis across the patients suggested that ultrasound can serve as a valuable tool for assessing optic nerve sheath diameter in idiopathic intracranial hypertension. The limitations of our study are small sample size, and papilledema grading was not compared with CSF pressure and optic nerve sheath diameter. And OCT and visual fields were done but not analyzed in correlation with optic nerve sheath diameter. To conclude, optic nerve sheath diameter by ultrasound and MRI show strong correlation, and they correlate positively with CSF pressure, and CSF pressure reduction was noted post lumbar puncture, and ultrasound is a valuable tool for diagnosis and follow-up, especially in resource limited settings, special scenarios as early point of care. These are my references. Thank you.
It's a good study, but can you tell me the clinical utility in the ophthalmology department? Because anyhow, to diagnose IIH, you have to subject the patient to MRI.
Yes, sir.
Can you tell me single one department where this can help? Whatever you have done, because it is a proven thing, because other department, there are one or two departments which regularly do this ultrasound for optic nerve sheath diameter. Can you tell me? Because in ophthalmology setup, when you are doing an MRI, there is no utility of this. What would you say?
Sir, during follow-up, when the papilledema is reducing
but anyhow, it should reflect on the optic disc also.
yes, sir.
So that is what I'm asking. It's a good study, no doubt. You have thoroughly employed yourself in doing this study. But the clinical utility in ophthalmology department. Other department, can you tell me which department is using this?
Neurologists?
No.
Neuro-ophthalmology.
It's CCM department or any department which is having an ICU. The patient is bed bound in coma. There, when they cannot dilate the patient's pupil, they want to know this is what is being employed in the critical care medicine or whatever the ICU they are. The only department, not in the ophthalmology department.
Yes.
Anyhow, it's a good study.
So you showed that graph about correlation.
Yes, ma'am.
So which statistical test did you use for making that correlation?
SPSS software was used, ma'am.
But which test specifically? Correlation test?
Ma'am, Pearson coefficient.
Pearson coefficient, okay. And all the patients were given only medical management, or any of them needed surgical optic nerve sheath fenestration?
No, ma'am, only medical
All
management.
medical,
Since
okay.
they were under study, they were under regular follow-up, ma'am.
So that has to be mentioned also, because I think that was not mentioned. What was the management? Because you were following them up, no?
Yes.
Thank
you, ma'am.
It depends upon what method you are employing. Because neurology people, they do this, okay, and when they are just putting, the CSF just comes out in gush, so you never have the opportunity to collect how much was collected. But okay, that can be a question.
Ma'am, actually it was not measured how much ml was taken.
Yeah, definitely it is used as a therapeutic measure also, many a times. Yeah, many a times.
Thank you.
Dr. Pooja. I think that.
Good afternoon, everyone. And this was actually a study which our Neuro-Ophthalmology department has been seeing so many papilledema cases because it's a multi-speciality hospital that I, as an anterior segment surgeon, and I said, let us just study this so that we can give some kind of a take-home or epidemiology to the type of papilledema we have amongst different age groups. So this was basically to study the demographics, etiology, and clinical features of all cases that were clinically diagnosed as papilledema when they came to us. So the secondary objective was to see that are there any differences broadly in any causes between the various age groups, pediatric versus adult population, and to study the variations in the clinical presentation, be it history or examination. So ophthalmic examination or investigations. So it was retrospective, record-based. We took 150 cases, and it spanned over 1.5 years, and it was in a tertiary hospital. The participants, everyone who was diagnosed as papilledema, any prior optic nerve dysfunction, we also ruled out demyelinating disorders. It was consecutive and convenient sampling. All patients had already undergone a detailed history, a good ophthalmic examination, and a neurological evaluation. Wherever needed, they underwent MRI, lumbar puncture, etc. So diagnostic evaluations meant an entire visual acuity, color vision, extraocular. We actually evaluated them based on these parameters, who came with anterior segment changes, who came with visual acuity deterioration, color vision diminution. Also, obviously the photography was done, OCT was done, and where needed, the visual fields were done. We also made them undergo serum levels of B12 and D3. As I said, we also asked them about their specific histories. So we saw that among the 150, we had 20 in the pediatric age group, the remaining in the adult age group. Among those in pediatrics, majority were males. And amongst the male and females, there was almost an equal distribution in craniosynostosis and inflammatory disorders, a slight male predilection for infections and tumors. But if you can see, a significant amount of pediatric population also showed tumors as the causes. And of course, the others were inflammatory, infectious, and craniosynostosis. These are the predominant causes where pediatric papilledema is concerned. Again, we see that craniosynostosis is more predominant in the earlier pediatric age group. The infections in the at both ends of the pediatric age group, and the inflammations and tumors are spread across somewhere in the middle of the pediatric age group. Our eldest child was around 13 years old. So it was from 2 to 12 plus or 13. We had modified this record. Anyway, this is just, I had checked it there, it was showing properly. It is all the 20 children, their diagnosis basically. Sorry about this slide, I checked it there, but it's not playing here. In adults, the 120 patients were divided again with a slight male predominance. Most of the diagnoses went, again, around 30% for tumors, and the remaining nutritional and idiopathic. If we included the autoimmune, the thyroid, and the inflammatory infectious, like TB, meningitis, etc., almost 90% of them were covered. Some were vascular, of which sinus thrombosis, AV fistula, anode carry were some of them. Drug-induced, yes, it was a senior resident from another department. These are the rough MRI pictures. Here you see everything ranging from infection, IIH, there's a midbrain contusion here, there is a sigmoid thrombosis, hyperplasia, there's this thyroid, these are all tumors, right from schwannoma, neuroblastoma, we had a whole range of them. Craniosynostosis would show some sort of a copper-beaten appearance and kinking of the optic nerve. Again, these were the fundus pictures, the infective causes, some dysthyroid, these were the infiltrative and the unilateral, some of them local causes. and of course the IH. So when we evaluated them as per their history, we found that adults had more of symptoms like headache, more nausea, vomiting, more than children did. Then of course, again, this is not showing with the lag of thought. Okay, so in children, the lag of the proptosis was more due to craniosynostosis, whereas in adults it was more due to dysthyroid. And color vision loss was more significant in children, definitely. Gaze deficits and nystagmus more in children. However, visual loss we found was more in adults. Children had more tendency towards hydrocephalus, and adults had more tendency towards a visual loss, again at a higher age. Keratitis again was mostly due to proptosis, and there was a sluggish pupil which was found more in children proportionately. And some cases, one could argue that they were not papilledema, but yeah, they're local tumors, infections, infiltrates, and one had infectious endocarditis due to atrial myxoma, which presented unilaterally or asymmetrically. So we had up to 12 years. Yes, hydrocephalus was more in children. We had a 1:5 infra and supratentorial tumors if we just see the tumors, because they were significant in both sets of population. And visual symptoms, of course, were more in adults. So the pathogenesis is more like when the intracranial pressure increases, there's axoplasmic stasis, which gives rise to the actual optic nerve swelling and subretinal fluid. And the sheath, when it gets distended, there's choroidal folds, and both together may cause venous obstruction, eventually axonal compression and optic atrophy. So in this classification, we had this entire range once we had classified them right from
times up.
yeah. So we had the entire range, and neuroimaging is important because well, it can show us the entire retinal ganglion cell layer, plexiform layer, and these are the highly elevated OCT, and you can actually see the true axonal edema. So this is just a summary of what I have already mentioned, and the conclusions are that though there were some vitamin deficiency also noted, we need to establish a causal link. Other than this, I've already discussed it all. And we need to promptly diagnose, suspect tumors, especially in both populations. Thank you.
Everything is fine, huge data. But the only point is, I think, the title. It should not have been papilledema.
So it
Because we
was
have not done
diagnosed. This is something that we as ophthalmologists or general ophthalmologists, we will say, oh, it's a case of papilledema, sent to the neuro-ophthalm or to neuro pediatrics. So, but these finally turn out to be so many different things, especially if they are bilateral. And yeah, you're right about that, because not all of them turned out to be papilledema as per definition.
Yeah,
and I think this was interesting because I think papilledema should have been under inverted commas.
Should have been disc edema, unilateral or bilateral. I think that would have been more appropriate term for this study.
Very true.
And you have mentioned that supratentorial, infratentorial lesions are more common in children, and they are more prone to cause your obstructive hydrocephalus. The similar is true with your infective etiopathologies. But I don't know what about your nutritional. 15% you have shown nutritional.
There was a deficiency of D and B12.
Can go to, because if the
maybe it needs more study for
the
that.
CSF pressure is more, then it would go into a definition of IIH.
True, but there
Not
was an
your-
IIH separately, especially with
I've
that
seen that. You have mentioned IIH separately.
retinol for some skin issues.
But that also comes under your papilledema, then your raised pressure, papilledema,
True.
nutrition, and IIH.
True, that again becomes
Yeah.
almost nutritional.
Thank you.
Thank you so much.
Dr. Sophia?
Good afternoon, everyone. Today I'm going to present a rare case of internuclear ophthalmoplegia. So INO is an aberrant gauge marked by an inability to adduct the affected eye, and the lesion is placed in MLF, medial longitudinal fasciculus, and pons. Most prevalent causes are ischemic CVA, demyelination from multiple sclerosis, and these two account more than 70% of INO. Coming to my case, a 61-year-old male came to our eye OPD with binocular double vision for 4 days, which was acute on onset, and vertigo for 4 days. On general examination, he was found afebrile. The heart rate and respiratory rate was within normal limits, but the blood pressure was 182/96, and he had no past medical history, and he was not on any blood pressure medications. Coming to the ophthalmological examination findings, his visual acuity, best corrected visual acuity in right eye was 6/9 and left eye was 6/9 parts. Pupil was round, regular, and reacting to light. On slit lamp examination, all the appendages and adnexa were within normal limits, and the lens had early lens changes, and fundus after dilatation was within normal limits. Other cranial nerves were intact. Coming to a squint evaluation, on cover-uncover test, my patient had a right eye 15-degree exo with adduction deficit of -2, which was not associated with pain on eye movement. And in the left eye, on abduction, he had nystagmus. So the etiology of double vision or diplopia, according to localization, can be intraaxial and extraaxial. Intraaxial are infarction, demyelination, tumor, hematoma, aneurysm, and extraaxial are oculomotor nerve palsy, which can be in subarachnoid space, cavernous sinus, and orbital apex. Coming to the investigation, all the routine blood tests were found to be normal, and on imaging, on MRI, there was infection in right medial pons. So coming to the pathophysiology, let's have a brief discussion. My patient with right eye adduction deficit on left gaze. So on left gaze, the right frontal eye field was stimulated, which sent the stimulus further to the contralateral PPRF, which then sent the stimulus in two pathways, one in the ipsilateral sixth cranial nerve and the other via MLF to the contralateral third cranial nerve. So in my patient, the right MLF was affected, so the stimulus could not go further to the right third cranial nerve. So there was adduction deficit. Coming to the management, on physician consultation, he was started on tab aspirin, atorvastatin, telmisartan, and for vertigo, he was started on betahistine. And alternate eye patching every 1 to 2 hourly has been advised. Then he was sent for neurology consultation. So to conclude, what seems harmless at first glance conceals a serious hazard. INO in hypertensive patients reiterates the need for aggressive blood pressure management to prevent further CVA. Timely diagnosis and effective treatment avert further complications. Thank you.
Thank you. Very nice case. Many cases have already been published about INO. So what is different in your case?
I'm different as such. He had no past medical history, and the blood pressure for hypertensive, it is not so common in hypertensive cases with INO. And in in diabetes and all, the INO cases are more, and most commonly it is seen in multiple sclerosis, trauma, and other like myasthenia. Sorry, these are the DDs in multiple sclerosis and trauma and.
Did you rule out these other causes?
Yes, myasthenia we ruled out, and there was no history of trauma, and the fourth nerve palsy was not there. We also performed the Parkes 3-step test. It was also not present, and multiple sclerosis. It is acute, but it is usually it is in the age group of 20 to 50 year, and there was no other findings of multiple sclerosis in neuroimaging.
How did you rule out myasthenia in this case?
Ma'am, myasthenia first there was no ptosis and there was convergence is normal in INO usually, and in myasthenia the convergence is abnormal, and it is a chronic, like gradually it develops. So, and there is a diurnal variation, but this patient didn't have any as such.
What was the MRI sequence which you have shown?
Yes.
What was the MRI sequence?
So it was a contrast, matlab, T2 contrast.
T2 contrast. So the radiologist has labeled it as an infarct.
It is a small infarct, and because his clinical in other findings were normal, so we have asked the patient to come for follow-up. He has just came once with this neuro imaging. So the radiology, as the other findings were going with the blood pressure, like ischemic, so he has been the treatment was in that streamlined to that.
It was sudden onset.
Yes, it was sudden on onset, and no past medical history was there, and he was not on any blood pressure medications. Thank you.
Dr. Basavraj.
The next speaker also can be ready so that we don't waste any time.
Good afternoon, everybody. I have a voiceover PPT, so let's see.
Optic nerve reduced refractive calcified nodules located over and within the optic disc. The global prevalence. Ranges between 0.3% and 2.4%. In adults, the prevalence is 0.4 to 2.5%, while in children it's 0.3%. Optic nerve reduction is postulated to occur secondary to slowing of exoplasmic fluid following the compromise of blood supply to optic disc, leading to the accumulation of calcified and degenerated mitochondria. Optic nerve reduction is a grade neutral and is a common cause of pseudopapular leading to a misdiagnosis. About 87% of optic nerve reduction have a visual field defect. Optic nerve reduction act as an independent risk factor for non-arthritic antihypertensive optic neuropathy and also are associated with many vascular complications like plane shift hemorrhages, CRU, and pericapillary CNV. This was a single-center prospective study where all patients who were diagnosed with optic nerve reduction at our center between January 2023 and June 2024 were included in the study. Detailed ocular and systemic evaluation was done on these patients. Multimodal imaging on different platforms was performed and necessary radiological imaging were done. A total of 38 eyes of 20 patients were included in the study, among which 14 patients were male and 6 patients were females. There were 3 male children in the study population. 18% of the patients had bilateral involvement, while 2 patients had unilateral involvement. At presentation, 3 patients were asymptomatic, while 5 patients presented with decreased vision, and 11 patients had a different or a misdiagnosis at the presentation. About 32 eyes in the study group had a visual field defect at the baseline. There were different associations of the patients with optic nerve reduction like CNVM, retinitis pigmentosa, fundal coloboma, amblyopia, and incidental post-traumatic reflex hemorrhage. Here are some of the representative cases. In case 1 is a 37-year-old female who presented with headache and eye strain and was diagnosed as benign intracranial hypertension elsewhere and was on estrazolamide for past 4 years. At presentation, patient was subjected to multimodal imaging and we diagnosed optic nerve occlusion based upon the fundus photofluorescence finding. In our study, about 24 eyes were on treatment for benign intracranial hypertension at presentation. Case 2 is of a 11-year-old male child who was diagnosed as optic neuritis and was treated unsuccessfully with 8 doses of intravenous methylprednisolone.
Here, at our center, FFA was done and it showed peripapillary CS node. Patient was successfully treated with anti-VEGF. He is a 31-year-old female who was diagnosed as retinitis pigmentosa with benign intracranial hypertension and treated with diamox and topiramate for 4 years while CSF analysis was within normal limits. On multimodal imaging, both the optic nerve head showed multiple irregular deposits on the surface and multiple bony spiculated pigments in the periphery. Fundus autofluorescence showed hyperautofluorescence area for optic nerve head, clinching the diagnosis of optic nerve drusen with retinitis pigmentosa. 87% of patients with optic nerve drusen have been described to have visual field defect. In our study, about 78% of patients had peripheral visual field defects, while 10% had enlarged blind spot, and 5% had isolated scotoma. Different platforms are available as a part of multimodal imaging for fundus imaging. In this study, Optox imaging system, Topcon and Heidelberg imaging system were employed for fundus picture and fundus autofluorescence. All of them have their own limitations. Among the following, Topcon fundus picture and Heidelberg fundus autofluorescence do have their edge ahead in the diagnosis of optic nerve drusen. Optic nerve drusen is a novel technique to identify the presence and locate the site of the optic nerve drusen. 90% of eyes had PHOMS adjacent to optic nerve head and 94% of eyes had hyperreflective mass above the lamina. Conclusion: it is necessary to differentiate between pseudo and true disc edema, and optic nerve drusen should be ruled out before making a definitive diagnosis of papilledema. We can educate the patient and create an awareness about the field defect and associated risk of developing complication associated with optic nerve drusen. Optic nerve drusen is a benign condition and a majority of patients requires observation only. Thank you.
Thank you. Very nice study. So, as you saw, so many ophthalmologists were treating them as IH. So, what message do you want to give these ophthalmologists when they see such cases? How should they go about?
A careful disc examination is the key feature here, ma'am. If you see any textbook, there is a difference, like there is a table where we can differentiate between pseudo disc edema and then true disc edema. Everything, like sometimes it might overlap among all those things, but two most important features are, one is the obscuration of the blood vessels. If the blood vessels around the disc or also in the peripapillary area is not obscured, it means you are dealing with a pseudopapilledema. That is one important point. Second point is the anomalous vascular branching, the bifurcation or else trifurcation of the vessels. If you see any bifurcation or trifurcation of the vessels over the disc, it means again you are dealing with the pseudopapilledema. These two are the most important features. These two features holds true for the other causes of pseudopapilledema, like hypermetropic eyes as well as myopic eyes.
And if they have a chance to do investigations,
yes,
which investigation?
It's one more thing, like it gives me it makes me happy that like whenever I stop 4-year, 5-year-old follow patients with our diamox, topiramate and other things, it gives me very like a kind of a pleasure that I'm going to stop all the drugs, and then I'm going to say that I'm just want to observe you every yearly with all these basic investigations. I see that happiness in my patient eyes. That is the one which gave me some kind of stimulation to do this study.
So you can say a simple ultrasound or a fundus autofluorescence will help.
These two are the most important things. Thank you.
What about your axial length and retinoscopy?
Sir, I didn't do any axial length because, sir, when we have a autofluorescence, we're not going to do ultrasound, because ultrasound is a subjective test. Unless you are looking it for like optic head drusen on the ultrasound, you are going to label it as a ONH. Otherwise, you might miss an ultrasound also, sir.
With the advent of your OCT and autofluorescence, that retinoscopy and axial length has taken a back seat, no?
Yes, sir.
Thank you.
Thank you, sir.
Dr. Pratibha.
Good afternoon, everyone. So I'll be presenting my case series of unusual headache in children. Headaches are very common and disabling problem for children and adolescents. Almost 60% of the children experience at least 3 headaches per year, and the similar trend is seen in the Indian data as well. The commonest cause being migraine and tension type headache. Headaches in children are frequently attributed to benign causes. However, persistent or atypical headaches warrant a deeper evaluation. So this was a case of a 5-year-old child who presented with holocranial headache, which increased in frequency since the past few weeks. He had occasional vomiting, and he had unusual episodes of crying due to headache. He had consulted a pediatric neurologist who started him on treatment, and the headache reduced in intensity. When he presented to us, the visual acuity was 6.6 and 6. Pupil, color, contrast, anterior segment on fundus was absolutely normal. After 20 days, the headache worsened, and at this visit, we can see there is presence of early disc edema, and there was SAF on B-scan ultrasound. So this child was neuro-imaged and was noted to have a very large cystic area in the temporal, left temporal region, and was diagnosed to have an arachnoid cyst. He underwent a left temporal mini craniotomy and endoscopic fenestration of the arachnoid cyst, and we can see that the SAF had resolved here. This was a case of a 14-year-old child who came with holocranial intermittent headaches in the past 2 years, which relieved after rest, and there were no aggravating factors. Her visual acuity was 6.6 and 6 with mild compound myopic astigmatism. Pupil, color, contrast, anterior segment and fundus was normal. So glasses were prescribed, and she was advised to consult a pediatric neurologist if the headache persisted. However, to our surprise, after 3 weeks, she comes back again with a sudden drooping of the right eye upper lid. Her visual acuity at this visit was 6.6 and 6 with a right eye ptosis, left face turn, and anisocoria with the right eye being the larger pupil. Her squint evaluation and extraocular motility were suggestive of a right third nerve palsy, which was involving the pupil. So on neuroimaging, it was noted to have a craniopharyngioma, which was compressing the right third nerve. She underwent neurosurgical, the visual fields were absolutely normal in this patient. The RNFL was normal. However, the GCC showed early binasal thinning, which was suggestive of a chiasmal compression. So she underwent a decompression procedure, and you can see that there was complete resolution of the third nerve. This was a case of a 16-year-old patient who came with holocranial headache, which had increased since the last 1 month. She was a known case of migraine since the early childhood, and she described that this time her headache is something unusual from the regular headaches that she gets. Her vision was 6.6 and 6, pupil, color, contrast, anterior segment and fundus was absolutely normal. She was referred to the neurologist, and incidentally on the neuroimaging was noted to have a large pituitary macroadenoma. Her visual fields were normal, her RNFL was normal, and the GCC showed early binasal thinning, again suggestive of a chiasmal compression. So there are certain important aspects of headache that one should be aware of. One should know the onset and the duration, like whether it is sudden in onset or progressive, the location and the character, whether we are looking at a severe or unusual pain, especially in the occipital and bifrontal region, the triggering factors and the timing, morning headaches, nocturnal awakening or aggravating with coughing and bending, the headache associated with symptoms like nausea, vomiting, visual changes, neurological symptoms, and if the daily living activity is getting affected, like if the child is missing school, sleep disturbance or inability to perform the routine task. Look out for red flag signs which are associated with systemic signs and symptoms like fever, weight loss, neurological signs like vision loss, any ataxia or cranial nerve palsies, occipital headache, high-risk groups, postural, in children with younger age group, associated with infective signs, squint and papillary edema, child waking up from sleep or early morning vomiting or thunderclap headache. So we know that MRI is the modality of imaging when it comes to ruling out any secondary causes. However, ophthalmic instrumentation like OCT, visual fields and B-scan also can help in clinching the diagnosis early. So the lessons that we learned from these cases was there is a need for a close follow-up, reevaluate any persistent headache at least within 1 to 2 weeks. Intracranial compression can present without any alarming red flags, so close follow-up is important. Pay close attention to the patient's description of the headache, and timely referral to the neurologist is a must. So I would like to conclude that persistent or unusual headache need more attention. A comprehensive approach is important. Recognize red flags, utilize advanced imaging techniques to clinch the diagnosis early. Timely interventions improves the prognosis and reduces long-term complications. and collaborative effort and awareness among clinicians is a must. Thank you.
Thank you. Very nice case series there. So no questions.
Thank you. The pituitary macroadenoma was a cause in that case. The 16-year-old, yeah. Headache also, and since she was a known case of migraine, I think that is where kind of got delayed, and later on the neuroimaging was done, because she complained that it was unusual. I think the patient was very, very clear that this headache is not what I get for the past so many years. So that was the reason why she was neuroimaged, and incidentally it turned out to be a pituitary macroadenoma. Yes, yes. Yeah, but in all these cases, the only symptom was headache. And even if there was craniopharyngioma or pituitary macroadenoma, except for the GCC early binasal thinning, there was nothing that could have, told us that do the neuroimaging at the first visit itself. So that was one thing that was quite surprising in all these cases. Yeah. Thank you so much.
Next is Dr. Gemini Isaac. Not there. Okay, fine. So Dr. Priyadarshini Palaniappan. Please go on.
Good evening, everyone. My topic is disc edema, differentials and management, case series report in a secondary eye care center. This is a case series report of 3 cases of different causes of disc edema. Case 1, a 70-year-old female presented with painful blurring of vision for the past 2 months. She is a known diabetic, hypertension and coronary heart disease patient. She was on irregular medication. Her BP was measured was 180, 120 millimeter of mercury. There was no history of any headache or fever. On examination, her BCV of right eye was 6.6 and 6, left eye was 6.12 and 8. The only color vision was reduced. Pupil reaction and extraocular movements was normal. Fundus image, both eyes, there was disc edema with splinter hemorrhages in both eyes. OCT showed disc edema in both eyes, and macula was normal. MRI brain was done, which showed small vessel ischemic changes. A diagnosis of grade 4 hypertensive retinopathy was made. Neurologist's opinion was taken, and the patient was started on systemic medications and anticoagulants. On follow-up, her both eyes vision improved to 6.6 and 6, color vision improved to 3/21. Fundus examination, there was resolving disc edema with temporal pallor. On follow-up, the both eye showed a inferior field defect. Case 2, a 51-year-old female presented with painless diminution of vision in both eyes. She is a known diabetic hypertensive patient on irregular treatment. On examination, BCV of both eye was 1/60 and 36. Her extraocular movements was normal. Pupil was sluggish reacting, and color vision was reduced. The fundus image showed both eye there was disc edema with splinter hemorrhages, and there was retinopathy changes in both eyes. OCT showed disc edema and retinal thickening with the hyperreflective foci more in the right eye. FFA was done. The right eye showed extensive disc leakage, NBD and NBE was seen, and both eyes there was extensive capillary non-perfusion areas. A diagnosis of both eye non-arthritic anti-ischemic optic neuropathy with proliferative diabetic retinopathy in right eye and severe non-proliferative diabetic retinopathy in left eye was made. She was started on systemic medications, insulin and oral medications, and laser was done in the right eye, and anti-VEGF bevacizumab injection was given in the right eye. Her field defect in the last visit showed severely depressed fields. On follow-up, her vision improved to 5/60 and 36, and left eye improved to 6/24 and 24. There was pale disc in both eyes. Case 3, 36-year-old female presented with painful blurring of vision in left eye with headache for the past 2 months. There was no any systemic history or any fever. On examination, right eye was 6.6 and 6. Examination of the left eye, the vision was 6/12 and 8. Pupil reaction was normal. There was vit cells in the anterior vitreous face. The right eye fundus was normal, left eye showed with cells. There was disc edema with superficial hemorrhages, and subretinal fluid was seen in the posterior pole. OCT of the right eye was normal, left eye showed disc edema and subretinal fluid. Investigation, baseline uveitic workup was negative. Only IgM leptospira was positive. Her MRI brain was normal. A diagnosis of left eye leptospirosis neuroretinitis was made. She was treated with intravenous methylprednisolone, oral doxycycline, and tapering oral steroids. On a 3-month follow-up, her vision improved to 6, and 6. Her eye was square. The fundus of the left eye, temporal pallor and RP changes was noted. The macula showed a resolved subretinal fluid. Discussion, all disc edema cases need careful evaluation of the history, whether they are taking the medications normally, and BP, RBS, and the MRI brain and orbit is advised. Medical therapy will depend on the underlying etiology. Non-granulomatous anterior-uveitis or pan-uveitis is the most commonly reported form of leptospirosis uveitis. IgM ELISA will help in the diagnosis. Treatment with oral doxy and systemic steroids give favorable results. Conclusion, neurophthal cases with the relevant systemic and blood investigation workup with the physician approach will help in the preventing vision loss and further treatments. These are my references. Thank you.
Thank you. So, in that first case, you diagnosed it as grade 4 hypertensive retinopathy. What were the points in favor of diagnosis?
Her BP was high, ma'am, 180, 120, and there was disc edema and splinter hemorrhages, and
like in that fundus photo which you showed us, only disc edema was visible. Huh? There were no soft exudates, no flame-shaped hemorrhages. You did a macular OCT and there was no edema also.
No.
So how did you come to that diagnosis?
She came to me in the first week itself. There was not many on the follow-up also. On starting the regular medications, within 2 weeks the disc edema resolved, and MRI brain was normal for her because she was 77 years and there was no headache. So this was a possible diagnosis.
Did you do other blood investigations?
Yes, I did a CBC, ESR and everything, and her sugar was under control. Only her BP was high, and fasting lipid profile was high, so that she was started on lipid tablets also.
So she had an inferior field defect.
Yes.
How do you explain that?
The small ischemic vessel changes, MRI, maybe that explains.
Thank you. So is anybody else who we have missed out? Okay, so very good effort from everyone. Everyone presented very well. Interesting cases. So we can all have a group photo, all the presenters.